Hello, everyone. A very good evening to all of you. I hope you are doing great. So today we are going to learn about the integrated pattern of physiology and biochemistry. Yes, I can see your chats there. Okay, thank you so much. I hope all of you are doing great. All of you, good evening. Good evening. Okay, fine. Chalo. So first of all, we are going to start with the integrated pattern of physiology questions. After that, we will be discussing about biochemistry. Okay. So first of all, physiology. First question for you people. After recovery from head injury, a man wants to reach for a glass of water, but his hand either stops in the midway or overshoots. On examination, he is not able to perform the examination as shown in photo. Injury of which of the following structure can cause this? So first of all, you see this question and I'm asking about this test. Okay, this is the test. And after that, I'm asking you, okay, this is the question. I'm asking you lesion of which part can cause this symptom? Okay, fine, chalo. So I'm going to give you the explanation. First of all, you can give me the answer. Okay, so let me explain you. First of all, being a student, if I'm going to say this question, if I have to assess this question, first of all, I will say, okay, like a structure number 1, okay, this is actually cerebellum. Structure number 2, okay, this is corpus callosum, okay. And what about a structure number 3? See, a structure number 3 is actually, okay, this is the pons. Okay, fine. Now, see, in this question, actually, what is happening here after the head injury, patient is not having a smooth coordination in voluntary movements. What I means, see, this question is something like, I hope you can remember that there is something called the, okay, nose and finger test. Nose finger test, if you remember this, nose and finger test. So basically, I'm asking my patient to perform this movement, but if he is not able to perform this movement, maybe, you know what, like suppose if I'm keeping one glass of water, I'm asking my patient to touch it. So whenever he's going to touch it, okay, like either he's going to stop in between or either his hand is going to overshoot. Okay, no, so it means what? He is not having a good coordination in his voluntary movement. So what can you expect? Okay, which part of brain can be injured here? So basically what is happening with the help of this nose finger test, that I can say that according to the clinical situation, my patient is having dysdiadokinesia. Okay, now dysdiadokinesia, I hope you remember this one. Okay, dysdiadokinesia. So what is the meaning of the dysdiadokinesia? See, alternate movement will not be able to performed. Okay, that will not be performed by the patient. Okay, dysdiadokinesia. So now I have to understand that injury of which part of the brain can cause this kind of symptom. So when I see about a structure number 2, corpus callosum, basic anatomy and basic physiology, when I have to understand that, okay, what were the functions of the corpus callosum? Okay, what were the functions? So I can say that, okay, fine, okay, like the function of a structure number this, okay, structure number 2 is what? Structure number 2, okay, function of this, like is to establish a communication between cerebral hemispheres. Okay, this is the first. After that, okay, like also maintaining the balance of arousal and the attention, right? Fine. And eye movement and vision also. So this is the function of the corpus callosum, and even the tactile localization, yes. And what about the function of the pons? See, what about the function of the pons? Okay, pons helps where? I hope you remember the function of pons. See, pons helps in maintenance of what? Autonomic nervous system, right? Autonomic nervous system. Okay, which we perform without thinking, like breathing and digestion. So pons helps there. So now when I know the function of corpus callosum and pons, then I can think that no, this is okay, this okay, movement function, okay, this all belongs to where? Okay, this belongs to cerebellum. Fine. So cerebellum. So cerebellum is responsible for what? Motor coordination. Fine, easy to understand. But now the second question is that, okay, so what about the what kind of differences will be there whenever there will be lesion at the lateral part of pons and the lesion at the medial lesion at the medial part of the cerebellum? Easy to understand. So let's learn here. See, whenever there will be lesion at the lateral part of cerebellum, at that time patient will be having dysmetria and dysdiadokinesia. Patient will be having difficulty in maintaining the range of motion. When you ask the patient to do rapid alternate movement, see, this is also the test. You ask the patient, okay, to do alternate movement, to flip his hand like this, okay, no, he will not be able to perform it like this. So this is what? This is actually dysdiadokinesia, dysmetria. See, dysmetria, all these are seen in the lateral lesion of cerebellum. Lateral lesion of cerebellum. So what exactly we see? Okay, dysmetria means inability to control range of motion first. Synergia, ataxia are there. Okay, no, fine. There will be incoordination. Fine. See, there is something important that is called as the dysdiadokinesia. Dysdiadokinesia, inability to perform rapid alternative movement. Fine. See, like if you are able to remember these 2 points, you can understand that these are happening because of the lesion in lateral part of cerebellum. But what about the midline? See, if there will be midline lesion, at that time, what will happen? Whenever patient is walking, patient can fall in any direction. Imbalance will be there. Okay, you ask the patient to walk and take sudden turn, he will not be able to take it. So that is called as inability to make a rapid turn while walking. Remember all these, okay, these 2 points here in the midline lesion. Remember dysmetria and dysdiadokinesia in the lateral lesion. So according to the question, what is happening here? Patient is having what? Dysdiadokinesia. Answer is a lateral lesion of cerebellum. Easy to understand. So this was the physiology question from CNS part, okay, brain part. So overall the summary of this part is that, okay, what are the functions of cerebellum? The most important is what? Smoothing and the coordination of voluntary movements. Okay, no, fine. So please remember this point that, okay, maintenance of the tone, posture and equilibrium, and then smoothing and coordination of voluntary movements. These are the functions of cerebellum. Okay, chalo fine. Aage badhte. Okay, next question for you people. See, after a building catches on fire, a pulseless body recovered from the building after a few hours. Body was taken to hospital for post-mortem examination, and presentation of body was similar to the given photos. I have 2 photos. Which type of hypoxia could have caused his death? Answer me, please. So basically, see, in this question, what I have done, that I have integrated forensic medicine and physiology. So now you answer me. See, Examiner can play in any direction. Examiner can frame question from any subject, and examiner can integrate any of these subjects. So here in this question, I'm asking you one question, okay, one clinical history related to forensic medicine and toxicology. Second is I have added physiology part. So basically the clinical history belongs to forensic medicine, but my question is of physiology. Now you think and you answer. See, you know what? See, when I see this question, when after a building catches on fire, a pulseless body recovered from the building after a few hours, okay? So you know what? When a person was in that building which catches on fire, so what happened there? After that, he died. You cannot see any burning part. You cannot see here, right? No, but I can see here, okay, this kind of discoloration. So which kind? What is the lividity of the body? Lividity means what is the post-mortem staining of the body? This is like cherry red. I hope you remember some part from the forensic medicine that in which type of poisoning post-mortem staining or post-mortem lividity will be like this color. This color is seen in CO poisoning. I hope you remember this one. CO poisoning. CO poisoning is the carbon monoxide poisoning. I hope you remember this one. And see, according to the clinical scenario, I can say that, okay, person was, okay, like he was in that building which catches on fire, right? No, so after that, okay, so he died because of hypoxia only, right? No, he died because of hypoxia only because, okay, so when he died at that time, there was asphyxia, fine now. So because of hypoxia, he died. So what was the reason of his death? Hypoxia was the main reason for the death. Fine. So when I see that, okay, this is, see, as per the postmortem staining, I can say that this is the case of CO poisoning. Now you have to tell me that CO poisoning is having mechanism of action like which type of hypoxia? Hypoxic hypoxia, anemic hypoxia, stagnant, or histotoxic. I hope you remember the basic physiology that hypoxic hypoxia means what? See, whenever there will be lack of oxygen, okay, now whenever there will be lack of oxygen, or like in high altitude, right? So there will be lack of oxygen. So there if a person is dying, okay, he is dying because of hypoxic hypoxia. What about anemic hypoxia? Hypoxia because of anemia, because of lack of hemoglobin. Means what is happening in anemic hypoxia? In anemic hypoxia, what is happening there? Oxygen capacity. Oxygen capacity. Remember this one. Oxygen carrying capacity is decreased. Oxygen carrying capacity is decreased in anemic hypoxia. So how it is happening? How oxygen carrying capacity is decreasing? Please understand that CO is having more affinity. See, this is hemoglobin and this is oxygen. So whenever oxygen and hemoglobin, when they stay together, they work awesome. Okay, no? Oxyhemoglobin is there. Fine, no, oxyhemoglobin is there. But hemoglobin is high. Okay, hemoglobin is having more affinity with CO. With CO, approximately 200 times more. So what will happen? Say in a case of burn, in a case of fire, when CO will enter into the respiratory tract, when CO will enter into the blood system, into the body, after that, CO is going to take hemoglobin away from oxygen. Now, oxygen is far, CO and hemoglobin, they are staying together. Oxygen is there, but hemoglobin has left the oxygen. So what is happening here? Because of the oxygen, this kind of color is there, red discoloration is there, fine. But hemoglobin is not available for the person, fine. So same situation is happening where? Whenever there will be anemic hypoxia, anemic hypoxia. So please understand that CO poisoning is having the same mechanism like anemic hypoxia. So in this question, answer is what? This is a case of CO poisoning, and this is what? Anemic hypoxia. Anemic hypoxia. You can ask me, sir, red discoloration is also, this is also seen in cyanide poisoning. Cyanide poisoning, you can ask me right now, कि sir वहां पे भी red कुछ दिखाई देता है, ऐसा something like that. So please understand that whenever there will be cyanide poisoning will be having which color discoloration? Bright red. Bright red. Bright red, or you can say the brick red. Cyanide poisoning is having which type of post-mortem staining? Cyanide poisoning having the brick red color. But please understand that one more question can be asked here related to the poisoning. What actually cyanide poisoning do? Cyanide poisoning, what cyanide does actually? Please tell me. Cyanide is going to block what? Cyanide is going to block what? Answer me, please. See, I can see your answer. Please answer here. Yeah. See, please understand cyanide. What actually cyanide does? Cyanide is going to bind with ferric, with the ferric part of, cytochrome oxidase. Right now, cytochrome oxidase. I hope you remember all these points of, biochemistry. So even biochemistry can be, integrated with, integrated with forensic medicine for sure. And after that, questions can be framed. So cyanide is going to bind with ferric of cytochrome oxidase. Fine. So after that, what is happening here? Cytochrome oxidase system. So now, this is going to block what? ETC system, electron transport chain. And after that, there will be decreased ATP, and because of that, cells are not able to use oxygen. So there is what? Cellular hypoxia, cellular cells or the tissues. So what is happening there? In a case of cyanide poisoning, cells and the tissues are not able to use the oxygen. So in a case of cyanide poisoning, which type of hypoxia will be there? Histotoxic hypoxia. Cells and the tissues. I hope you remember this one, right? So histotoxic hypoxia in cyanide poisoning. I hope this is clear to all of you. CO poisoning, answer is B, anemic hypoxia. Fine. Okay, moving to next question now. Braille is a system of the touch reading and writing for blind persons, in which raised dots represent the letters of the alphabet. Which of the following mechanoreceptors helps in this process? So basically, I'm asking you. Which mechanoreceptor is helping the blind people to read the Braille. See, this is the system, right? So Braille lipi कहते हैं हिंदी में Braille. Fine. So what is happening there? You might have seen blind people. Okay, they will touch, and after that they will understand. Okay, no. So after that they are going to. So as per they touch, they are going to read. Okay, what is written over there? Easy to understand. Fine. So basically, I'm talking about what? I'm talking about the mechanoreceptors. So these are the sensory receptors which are present in our skin. Okay, no, so mechanoreceptors. So these are going to sense, so like these are going to sense like either the like small touch, superficial touch, deep touch, pressure and vibration. So I hope you remember all these parts. So Meissner's corpuscle, Merkel's disc, Pacinian, and Ruffney's end organ. These are our mechanoreceptor, but these are responsible for the superficial touch, deep touch, for the vibration and the pressure. So please understand this point here. Okay, so please understand this point here that, okay, for superficial, okay, for these superficial mechanoreceptors like, okay, slowly adapting and the rapidly adapting. Okay, no, so what is happening here? Okay, so what is happening here? Please understand that, see, like rapidly adapting mechanoreceptors. Okay, rapidly adapting mechanoreceptors. Okay, see, see, for the blind people, okay, they're going to learn it as per the slow. So they need actually slowly adapting mechanoreceptors. Okay, so that is actually the Merkel's disc. Okay, that is actually the Merkel's disc. See, like for the deep touch, pressure and vibration, we have roughness and Pacinian. I'm talking only about the Braille. For that, I need slowly adapting mechanoreceptor. So that is the Merkel disc. So answer is what here? B. See, all these things you are going to learn in detail in your physiology. Fine, but I'm giving you the orientation that what kind of questions examiners can frame, what kind of questions are being asked in MCI exam these days. Okay, fine. Okay, next question. Adrenaline is added along with local anesthesia so that there should be less bleeding on local surgical spot. This action of adrenaline is produced by the stimulation of which receptor? 100% this is the case of physiology. I'm telling you, this is the question of physiology. But I have asked you this question from the part of surgery, or you can say anesthesia, or you can say this is the question of physiology. Fine. Or you can say this is the question of pharmacology also. Fine. When I talk about adrenaline, okay, adrenaline and epinephrine, okay, pharma also, chalo, fine. Okay, that's a drug. Fine. No. So basically, you know what? Like this question, this is a simple question. Basically, what is the main question here? Adrenaline, action of adrenaline is produced by the stimulation of which receptor? That's it. Please answer me. A, B, C, D here. Very easy question for you. Chalo, theek hai. I'm going to explain this one. Yeah, please understand that whenever I'm going to operate in minor operation theater, okay, minor operation theater, what is happening? Like suppose if I have a local case, like suppose if I have to remove a ganglion or any lipoma or something, you know, like local, okay, like some small procedure where I have to give only local anesthesia. Okay, fine. So when I have to give local anesthesia, at that time, after giving incision, what will happen? There will be pooling of blood. I cannot operate when there is so much blood. I cannot operate when, okay, whenever there is pooling of blood. So that's why I need one assistant who can mop it frequently so that I can play safe. I should have open playground. Fine, no? I should have neat and clean playground. Whenever I'm going to, suppose if I'm operating over the forearm, I have given one incision here. After that, I should see, you know what? I should see less bleeding. But when I have given incision, bleeding will be there for sure. So there can be pooling of blood, but I may not be able to see the part where I have to operate. So I'm adding one medicine. So either I should have one assistant who is going to mop it frequently, but I can add one more thing that is called as adrenaline or epinephrine, whatever you say. Okay, no? Fine. So what is the function of adrenaline? Now you tell me what is the function of adrenaline. First question, okay, what is the function of adrenaline along with local anesthesia? Okay, no, so I can say that this is going to increase the effect of local anesthesia. This is going to prolong the effect of anesthesia. Fine. Now you tell me adrenaline is vasoconstrictor or what? Or dilator? Answer me, please. Of course, adrenaline is vasoconstrictor. Okay, vasoconstrictor. Vasoconstrictor means what? After that, when I have added adrenaline is going to do what? Adrenaline is going to do vasoconstriction of blood vessels. Okay, when there will be vasoconstriction of blood vessels, after that there will not be bleeding for sure, right? Easy to understand, no? Fine. So adrenaline is vasoconstrictor. Now you tell me, vasoconstriction means the constriction of blood vessel is stimulated by alpha 1, alpha 2, beta 2, beta 3. Easy to understand? Yeah, please understand that alpha 1, fine, no? Alpha 1, which is present in our skin, okay, like fine, skin and as a mucosal part, splanchnic blood vessels and all. Okay, beta 2 will cause what? Okay, beta 2 will cause what? So that is going to cause the dilatation. Easy to understand, no? So overall, I'm talking about adrenaline. Adrenaline is doing vasoconstriction with the help of alpha 1 receptor. Answer is A. Now I can ask you some more clinical questions related to adrenaline. See, just now I have told you that adrenaline is going to cause vasoconstriction. Fine. Now suppose if I am going to operate over the tip of index finger or over the tip of middle finger. Now you tell me at this part, I am going to use adrenaline along with local anesthesia. Answer me please, yes or no. See, please understand that. See, please understand that at any place, wherever there are end arteries, do not use adrenaline. End arteries are there. Do not use adrenaline because this will cause vasoconstriction. And after some time, what will happen? Because they do not have any other blood supply, fine, so there can be necrosis. So please, whenever there will be end arteries, do not use adrenaline. Do not use adrenaline. Okay, fine. Chalo. Okay, next question. Yeah, very good, very good. I can see your answers here. Very good. So suppose, like, okay, next question. Okay, next question. Suppose if by mistake adrenaline has given, then, okay, then which drug you are going to use there? Okay, to reverse the action of adrenaline. Right, so of course, which is going to vasodilate the fine, like phentolamine, right? Fine. Chalo, aage badhte hain. Next question. After an RTA, a person suffered severe head injury. All of the hormones will be affected except ABCD. Very easy question. Itna sa dimag lagao bahut hai, more than enough to solve this question. See, I'm talking about head injury. See, very easy question. Actually, I would say this is the easiest clinical question which you will get, I'm telling you. Head injury, so all hormones related to head, or all hormones related to the, okay, related to all the glands which are present in head. So now you can understand this question. This is a very easy question, I'm telling you. See, now you tell me, see this question, now you tell me here, I'm talking about prolactin, vasopressin, adrenocorticotropic hormone, ACTH. These are secreted by which gland? These are secreted by which gland? These are secreted by anterior part of pituitary gland, right? What about somatostatin? Answer me, please. What about somatostatin? Somatostatin, like this was, okay, this kind of question was asked earlier actually. Okay, see, like in that question they have given, option was insulin. So please understand, somatostatin is secreted by the pancreas. D cells of pancreas. Answer is C here, no, right? Answer is C. Fine, easy to understand. Very good, very good, very good. Next question. See here, this question. A 55-year-old male follow-up case of COVID-19. I hope all of you are familiar with the cases of COVID-19 because, you know, like even this time in recent FMGE exam, which was conducted on 18th June, I think 3 or 4 questions were asked from COVID-19. Okay, so post-COVID complications are so many, right? So see this case, a 55-year-old male follow-up case of COVID-19 presents with shortness of breath during exercise. He is having dry cough. He's having the tiredness and joints pain. His radiological images are shown below. Which of the following is correct about his condition? Basically, this is a question of medicine. Okay, no, fine. This is a question of medicine. I can say this is a question of medicine. I can say this is a question of pathology. But I can also say this is a question of radiology. Finally, I am asking you the question of physiology. Are you able to integrate all these questions, all these points? So basically, what do you see here? See, what do you see? See, if you are not familiar with the X-ray and CT scan images, then, you know, like there will be, you know, like you will be in trouble. So basically, when I see this post-COVID complication, I can see that there is fibrosis. Okay, now there is fibrosis. Basically, this is a case of pulmonary fibrosis, which is also a post-COVID complication for sure. So when I get to know that, okay, fine, post-COVID, my patient is having pulmonary fibrosis. Now, after that, first of all, according to this clinical situation, I have to diagnose the case. When I have diagnosed the case, after that, I'm going to looking after pathophysiology. And these 4 options are related to physiology only. Please tell me, what do you know about pathophysiology of pulmonary fibrosis? So now you have to differentiate here. When I talk about pulmonary fibrosis, this is obstructive lung disease or a restrictive lung disease. Now this is a different pattern. Now this is a different scenario. So that's why clinical question will take time. If you can correlate each and every part, then you can solve it very much easily. Let's understand it. See, overall, there are 2 types, right? Obstructive lung disease and restrictive lung disease. I hope all of you know this basic physiology. So let's talk about, see, as we know that all interstitial lung diseases like pneumoconiosis, occupational lung diseases like silicosis, asbestosis, anthracosis, and byssinosis, all these are what? Interstitial lung diseases, right now? Fine. And pulmonary fibrosis. These are restrictive lung disease. When I talk about COPD, asthma, bronchitis, and bronchiectasis, these are obstructive lung disease. But when I have to speak about pulmonary fibrosis, let's talk about restrictive lung disease. What is happening in the restrictive lung disease? In all these pathologies, in all these diseases, what is happening there? These diseases are going to restrict lung expansion. After that, there will be problem in lung expansion. So what will happen when lung is not able to expand? Then the total lung capacity will be decreased, residual volume, functional residual capacity, all these, first expiratory volume, all these are going to be decreased. All these are going to decrease in a restrictive lung disease because lungs are not able to expand. I hope you know the meaning of residual volume, total lung capacity, functional residual capacity and all. Please go through your physiology. Okay, I'm just giving you the basic orientation that what kind of clinical questions, will be asked. Fine. So because lungs are not able to expand, lung capacity, residual volume, all these parameters are decreased. But one ratio is there, forced expiratory volume in first second to the forced vital capacity. So what is happening? This will be normal or increased. in restrictive lung disease? Answer is C. Fine. Yeah, but all these parameters will be seen. A, B, D, A, B, and D. These are seen in obstructive lung disease. C is seen in restrictive lung disease. Since I asked you the question of pulmonary fibrosis, which is actually a restrictive lung disease, answer is C. Actually, this was a beautiful question. But you know what? When you are in examination room, you do not have that much time, but I suggest you that you have to practice in this way only. When you are going to study your physiology, please understand that physiology, anatomy, biochemistry, all non-clinical subjects are very, very important to understand your clinical subjects. Okay, so please understand that if you are very good in physiology and pathology, and I can say pharma also, or at least physiology and pathology, you will do great in solving all medicine questions. All medicine questions. Okay, I hope this is clear to all of you. So please, whenever you are going to start your preparation, whenever you are going to start, start preparing for like FMGE December exam, whenever you will start learning physiology subjects, please learn in this manner. You have to integrate each and every point with other subjects also. Okay, chalo fine. So that's all about physiology. Okay, now we are going to learn some integrated pattern of biochemistry questions. Okay, earlier what was that? See, earlier biochemistry questions were like this: which enzyme deficiency is seen in Gaucher's disease? Which enzyme deficiency is seen in Lesch-Nyhan syndrome, in phenylketonuria, in Alkaptonuria? So one-liner question used to be, that was the blueprint of FMGE, right? That was the old pattern. Fine. But now, even biochemistry, physiology, all questions will be asked in an integrated manner, in a clinical fashion. So first question for you of biochemistry. See this one. This looks like very big question, and you might be scared. Oh my God, this much big question, and after that you are not going to see this question. Fine, but this is very easy question. Please see this question. A 45-year-old man presents to a clinic with complaints of weight loss, frequent urination, increased thirst and appetite. Okay, so these are the clinical symptoms which are giving me a hint. Patient is having diabetes. Okay, this is just a hint. But after that, I have more history. His father had similar symptoms who was on metformin. Oh, complete clue here, pharmacological part here, who was on metformin for last 7 years. His father had, okay. So I can say that there can be, familial predisposition here, who was on metformin. So as we all know that metformin is a drug for diabetes mellitus, right? Chalo, good. Clinician wants to check his sugar level, and a lab technician has collected his blood sample in the given tube. Means, this tube which is having a gray color, cap. This sample tube has one agent that ensures that further breakdown of glucose will not happen, so that accurate level of glucose can be estimated. Which of the following is a right statement related to this scenario? I think I have asked this question before also, but please see this question, read all options, then you mark. Option number A, potassium oxalate inhibits enolase enzyme. Option number B, this is a plain tube which does not have any extra ingredients. Option number C, sodium fluoride inhibits enolase enzyme. Sodium fluoride has no role. Okay, fine. Actually, very easy question. I think, see, when I see this gray tube, and if I have basic clinical exposure, when I have this much exposure that I have collected the blood sample from so many of my patients, and I have sent for, blood investigations. So I remember, fine, gray color tube I used to use for sugar collection. I remember this one. But I do not remember what is the ingredient of, what is the constituent which is added in gray color tube. what kind of anticoagulant is added here, and what is the use of adding these, okay, like adding these elements here, adding these compounds here. So please understand that I have a patient who is a case of diabetes, or I am suspecting that my patient is having diabetes. I want to send blood sample for glucose estimation. I want to check his, like, okay, fasting blood sugar as well as postprandial blood sugar. Fine. But you know what is happening here? When, okay, blood was taken from the patient, and after that, actually lab is very far from my clinic. Lab is at least half an hour far from my clinic. So this can be possible that when blood was taken out, and after that, if there will be further metabolism of glucose, what will happen? After the metabolism, I may not get the accurate level of glucose. I hope you remember the glycolysis pathway. Okay, see, there will be further breakdown of glucose. So glucose will be converted into glucose 6-phosphate. Okay, so this will be converted into fructose 6-phosphate, and this will be there will be more breakdown, like fructose 6-phosphate that will be converted into fructose 1,6-biphosphate. So further, okay, see, like sequence, and finally this will become what? Finally, okay, there will be the product that is called the pyruvate. Okay, pyruvate. See, if there will be further breakdown of glucose like this after half an hour, because what is happening just after taking the sample, okay, when, like after that, what will happen when it is exposed to oxygen? Okay, after that, there will be aerobic glycolysis and all. Fine. So there can be further breakdown of glucose. I may not be able to get the accurate level of sugar in my patient. So I should add something in this tube which is not going to allow glucose to break down further, to break further. Easy to understand? So for that, I am adding something called as sodium fluoride. Sodium fluoride. See, the second step of glycolysis pathway. Okay, see, first of all, there will be conversion into phosphoenol pyruvate. After that, there will be conversion to pyruvate. Okay, no? So so just before phosphoenol pyruvate, sodium fluoride is going to block enolase enzyme, so that there should not be complete breakdown of glucose, so that I can get the accurate level of glucose. So please understand that one thing is sodium fluoride, which is added here in this tube, and one more thing is there which works as anticoagulant. Repeatedly asked question. Okay, please understand that sodium fluoride and potassium oxalate, sometimes they can ask you in a different clinical manner that in a tube, in a blood collection tube, what is the function of potassium oxalate? Please understand that potassium oxalate works as anticoagulant, so that till the blood will be received by the lab technicians there in a lab. Okay, like at that time, everything should be normal. So one thing is there which is working as anticoagulant, and one ingredient which is going to stop the further breakdown of glucose. Fine. I hope this is clear to all of you. Sodium fluoride and potassium oxalate. Sodium fluoride and potassium oxalate. These two are added in this gray tube. Fine. Sodium fluoride is blocking enolase enzyme, which is going to stop at the phosphoenol pyruvate, before phosphoenol pyruvate only, so that there should not be further conversion. Fine. And sodium and potassium oxalate. Fine. Oxalate is working as anticoagulant. Fine. So answer is C here. Fine. So okay, see, like this is a repeatedly asked question. See, sometimes, like they can give you a sample tube. And after that they can ask you, okay, for which blood investigation? we are using, okay, we are using this tube. For which blood investigation we are using a red tube? For which blood investigation we are using yellow tube? This is repeatedly asked question. So please understand some basic point related to these, okay, related to these tube. See, please understand that whenever I have to do serological examination in biochemistry lab, okay, like lipid profile, LFT, KFT, I will be checking what? I will be using the red tube, fine, no, for the serological examination, fine. Most important is the purple tube here. Most important is the purple. See, all are important for sure. Okay, purple, see the purple and red. Purple and red. These are most commonly used in hospital. Fine. So purple में क्या क्या करेंगे हम लोग बताओ? CBC है ना, complete blood count. जिसमें complete blood count में पूरा, okay, for like even for the blood grouping, for the cross matching, for hemoglobin and all. Okay, so for that, okay, purple will be used. What about sky blue? What about sky blue? This one, sky blue for the bleeding profile, right? जैसे APTT and PTINR. Okay, for that we are using which one? For that we are using sky blue. And just now we have learned about the gray color for sugar test, right? For sugar. So these are the basic which we are using. Okay, these four are frequently used in hospital. But most commonly is, okay, most commonly is what? Red, purple, and okay, red, purple, and the gray. See, red में जैसे कि even के lipid profile also, right? No, lipid में जितना भी वो सारा red. Okay, fine. But what about others? What about the green and yellow and black? ये थोड़ा important, थोड़ा interesting है. So can anyone answer me? For which blood test we are using yellow sample tube? See, yellow is used for HLA testing, DNA testing, you can say. For the paternity, right? What about the green one? Green one, ammonia, renin, insulin, all these are, okay, no, all these are used in the green tube. Okay, yes sir. See, actually there are so many blood investigation, but I'm just telling you the basic which you should keep in your mind. What about the black one? Anyone can answer me? Black one, see, the black one is used for the pediatric ESR. Okay, no? I hope this is clear to all of you. Okay, see this one, please, I would ask all of you to remember all these points. See, like so many times they are asking EDTA, right? No, EDTA is added where? EDTA, fine. No, this is, okay, this is in the purple one. Okay, sodium fluoride, just now we have learned sodium fluoride and potassium oxalate in gray, fine. No? So please understand that red is called as a plain tube. Red is called as a plain tube, means no anticoagulant is added, because we have to separate the serum there, fine. So when after the collection of blood, we are going to keep it for some time, fine. So then serum will be separated, fine. See, in the green there will be heparin, fine. So please remember all these points. Okay, these are repeatedly asked questions related to your clinical practice. Okay, chalo, next question. Very easy question for you. See, I hope all of you can answer this one. See, I'm asking you biochemistry question, fine. A patient presented with complaints of some abnormal deposits in eyes and ear, as shown below. Okay, suspecting a metabolic disorder, clinician did his X-ray spine and urine analysis. This is X-ray and this is urine analysis, fine. On examination, clinician saw some deposits and, like in his sclera, in his ear. I hope you can see this one. Okay. I hope you can, okay, you can appreciate a kind of deposition here and a kind of deposition here. See, you know what? See, when I learned biochemistry, of course, metabolic disorders are very, very important. Metabolic disorders like phenylketonuria, alkaptonuria, or tyrosinemia, right? Fine. But even I don't remember anything. This is a very, very famous question. Very, very famous question. Urine will be converted into black urine. This is a very famous question, right? Even if I have not given you this much clinical scenario, on the basis of this one, you can diagnose. Acha, yes, I learned that. Okay, so this was in phenylketonuria, this was in alkaptonuria, this was in the tyrosinemia. No. Okay, in phenylketonuria, this was the 𝗏𝐶 order, right? So these are the few things which you are able to recall, right, from the one-liner question which you have memorized. But yes, finally you will be able to recall. No. This was the alkaptonuria. This was the alkaptonuria when, okay, where urine was becoming dark after exposure to the air. Fine, no? So now when you are able to diagnose, this is a case of alkaptonuria. Alkaptonuria, then do you remember the deficient enzyme or the enzyme deficiency which is causing alkaptonuria? Now, this is the question of biochemistry. See, this is a clinical question, completely clinical question related to your lab investigations and all. But finally, you have to answer me what? Answer me the question of biochemistry question here, right? Biochemistry. So do you remember this one? Very easy question. See, homogentisate oxidase. Do you remember this one? See, please understand that alkaptonuria is due to deficiency of homogentisate oxidase. So what is happening is sometimes they can ask you in this manner also, why there is blackening of urine after exposure to air? Why? Okay, due to which compound? So please understand that. See, whenever there will be spontaneous oxidation of homogentisate into benzoquinone acetate. Okay, no, so this benzo, so this is happening because of the benzoquinone acetate. So this can be your question. Fine, no? So these are what? So these are actually the brown pigment alkapton. Fine, no? So this alkapton gives the black color to the urine. So this alkapton deposition can also be seen in ear, nose, cheeks, and sclera, and even in intervertebral disc space. Fine. So what is happening there? Even there can be deposition, and there will be what? There will be calcification of intervertebral disc. So what is happening here? So according to the clinical situation, I have diagnosed the case. This is a case of alkaptonuria. Which enzyme deficiency? Homogentisate oxidase. Answer is B. Fine. So please remember this question that, see, I have mentioned here all, okay, like all these three metabolic disorders, like along with the deficient enzyme. Okay, whenever there will be deficiency of phenylalanine hydroxylase, there will be phenylketonuria, hydroxyphenylpyruvate hydroxylase. So these type of things you have to memorize. Okay, all of you have to memorize. But see, my intention to teach you all of these things. Why? Okay, so what is the intention here? Simply to make you oriented that what kind of clinical questions are being framed in biochemistry. Okay, all these things you have to memorize, you have to learn in your biochemistry. Okay, chalo, next question. A patient presents with rashes over his hands and diarrhea. Okay. On general examination, he has hyperpigmentation over his neck as depicted by this photo. I'm talking about this one. What can be the probable cause for this condition? I'm sure, okay, see, this photo is this much famous that most of you would have diagnosed the case. I'm sure most of you would have diagnosed the case just after, even I'm not giving you the clinical scenario, most of you are going to diagnose the case just after seeing the picture. So what is the diagnosis here? Please tell me, what is the diagnosis? Of course, all of you know this is the case of Pellagra, right? This is the case of the Pellagra. Okay. So I hope all of you remember that, okay, pellagra is due to deficiency of one vitamin, and that was vitamin B1, B2, B3, B6 or B7. No, this was vitamin B3, right? B3, vitamin B3, which is called as the niacin, right? Vitamin B3. So whenever there will be deficiency of vitamin B3, which is called as the niacin, okay, there is a disease that is called as the pellagra, vitamin B3. Okay, fine, vitamin B3, fine. But option mein to vitamin B3 hai nahi. But there is no option of niacin, because whenever you are going to see this question, you are anticipating, okay, there will be vitamin B1, B2, B3 or okay, B12. But I have not given you the option of niacin. Now you tell me if you are able to correlate with metabolism of amino acids. If you are able to recall the metabolism of the tyrosine, histidine, and the tryptophan branch chain amino acids. So now you tell me niacin is a product of which amino acid? This can be the question. But if you remember the metabolism of the tyrosine or the tryptophan or histidine or branched chain amino acids, then only you can answer me this one. Yes, most of you are correct. Dr. Pradeep Patidar. Okay, Dr. Ansal. Very good, very good. Famous question. Yes, I can see that. Okay, Dr. Ranjit Singh. Yes, chalo, all of you. Very good, very good. तो ये कौन सा है? ये बताओ, first of all, you tell me what is the name of this appearance? बताओ क्या है? I'm asking you, what is the name of this appearance? See, this is called as castle necklace appearance. Okay, this looks like, okay, this looks like a necklace. Okay, no, this looks like a necklace. Easy to understand. This looks like a necklace. So this is called this is known as castle necklace sign or appearance. So you can tell me that, okay, fine, this can be the question. Okay, this can be the question of dermatology. And this can be the question of skin. Okay, dermatology. Yes, for sure. Okay, this can be the question of medicine. Yes, fine, accepted. Fine, but finally, I'm asking you the question of biochemistry. Biochem. Answer me, please. I hope you remember the metabolism of this one. Metabolism of the tryptophan. Please understand that what is happening here. See, always understand that. See, always understand that. See, whenever there will be disorder in the metabolism of tryptophan, okay, this is going to cause a disease which is called the Hartnup disease. See, in Hartnup disease, okay, patient will be having what? Okay, patient will be having rashes like some skin, okay, skin symptoms, and there will be neurological symptoms also. So what is happening here? Deficiency of tryptophan, it leads to decreased synthesis of serotonin 5-HT3, fine, no? Serotonin 5, okay, no? So serotonin and niacin. See, so what is happening here? Whenever there will be niacin deficiency is called, okay, niacin deficiency is going to cause the pellagra. So what is the meaning of the pellagra? See, like we remember with the mnemonic that is called as the D4 syndrome. This is also called the D4 syndrome. First of all, patient will be having what? Okay, first of all, patient will be having dermatitis. D4 dermatitis, like all skin rashes here. Fine. After that, there will be diarrhea. After more progression of the disease, okay, finally patient will be having dementia. And if you do not, okay, suppose if you do not manage the patient on time, then there can be death. Okay, so dermatitis, diarrhea, dementia, and death. So this is called the D4 syndrome. This is called the pellagra. Fine. So, but this is actually long course. Fine. So in the beginning, there will be diarrhea and dementia. So diarrhea and the skin rashes. Fine. And due to serotonin deficiency, patient will be having what? Patient will be having the neurological symptoms. Fine. So please understand that for every 60 milligram of the tryptophan, okay, 1 milligram equivalent of niacin can be generated. So basically, niacin is made from where? Niacin is generated from where? From the tryptophan. Okay, no? So here in this question, answer is C. Answer is C. Fine. See, you know what? See, I have just given you the basic example. What kind of questions can be asked? Okay, so many questions can be asked. So I can understand that whenever first amino acid is tryptophan. So, you know, like further, after the further metabolism, there will be production of 5-HT, okay, serotonin. So there can be, okay, no, finally, so there will be production of niacin also. So here, you know what? If there is a word of serotonin, then clinical question can be asked related to carcinoid syndrome also. If serotonin is there, then question can be made related to neurological symptoms also, related to psychiatric symptoms also. So why I'm teaching you all these points? All these points are important to understand that on the basis of each and every word, on the basis of each and every byproduct, a clinical question can be framed. Easy to understand? Fine. I hope this is clear to all of you. Okay, now? Okay, Chalo, I would like to give you some more information related to this one. Okay, how to memorize all these points. Okay, please understand this one here. How to remember all these points. Okay, how to remember all these points. So this is, okay, what I'm teaching you. This topic is related to biochemistry only. Okay, fine. Okay, first of all, whenever there will be metabolism, tryptophan, okay, no, fine. So after that, there will be a further metabolism. This will lead to, okay, 5-HT, which is called the 5-hydroxy, tryptophan. Fine. After that, this will form what? See, this is called, okay, this is going to be converted into 5-hydroxy tryptamine, or mean, whatever you say. So this is called as serotonin. Fine. And after that further, see, after that further, this will be, so converted into acetylserotonin. Okay. And finally, this will lead to formation of the melatonin. Okay, now see what is happening here. See, at each and every point, there can be a question. See what is happening here. Everywhere one enzyme will be working, which you can remember from your biochemistry part. See, I'm asking you here, serotonin, melatonin, and the tryptophan. All these are the points for making clinical question. All these points, okay, no, all these points are related to, okay, no, like examiner, like suppose if examiner wants, he can make clinical questions out of all these points. Okay, chalo, fine. Okay, fine. Next question for you people. Okay, this question of a 55-year-old female presents with pain and swelling as shown in photo. Sudden attacks of pain comes often in night. Her KFT investigation shows uric acid level 9.4 milligram per deciliter and Creatinine is 0.9. Which of the following can be associated with her condition? Please answer me this question. See, in this question, what I'm asking you here, as per the clinical scenario, you can understand that her uric acid level is very, very high. Okay, uric acid level is very, very increased. Okay, no? So how much is the normal level of uric acid? See, normal level of uric acid is actually 2.527 milligram per deciliter. Fine. So this is the normal level, but in this female, uric acid level is 9.4 milligram per deciliter. So I can say that she is having hyperuricemia. Creatinine level is 0.9. This is in the normal range. So fine, see, you know what is happening here? I have one information here that she is having increased level of uric acid. And as we all know that whenever there will be increased level of uric acid due to hyperuricemia, one type of arthritis can happen in which there will be deposition of uric acid crystals in some joints, especially the great toe. And after that, what will happen? Okay, patient will have redness, swelling, and pain in the joint. This is called as gout. This is called as gout. Fine, no? Hindi mein gathia kehte gout. So I hope you remember this gout. And gout, where do we see hyperuricemia? So let's learn some point about the about the nucleic acids and all, where we have learned in purine metabolism and pyrene metabolism. Okay, purine and pyrimidine we have learned, and especially in the purine metabolism, we have understood that whenever there will be increased metabolism of purine in human body cannot contain purine. So after that, there will be catabolism. Whenever there will be catabolism of purine, there will be increased level of uric acid. There will be hyperuricemia, fine, which is going to cause what? Gout. And this picture is very, very famous picture. Okay, no, so redness and swelling around great toe, gout. So this is because of the disorder of purine metabolism. So this is a question of, you can say this is the question of what? Okay, this can be the question of medicine, or especially you can say this is the question of rheumatology. Fine. Okay, this kind of question can also be asked in orthopedics. Okay, fine. Easy to understand. But yes, finally, I have asked you metabolism problem here related to purine and pyrimidine. Fine. So this becomes the question of biochemistry. Answer is B only. Next question. A 9-year girl is presented to you. Okay, like is presented to your clinic with complaints of acute abdominal pain on and off with the tingling sensation of limbs. Her mother is informing that she used to be fond of eating paint from the wall of newly built house. Which enzyme deficiency can cause these symptoms? So basically, my 9-year-old patient, she is having a psychiatric problem, I can say. Okay, that is called as the pica. Okay, most of the young patient, they will be having this kind of disorder, that is called the pica. Pica means what? Appetite for non-nutritive substances like eating clay, sand, or the chalk, any non-nutritive substances, that is called the pica. Okay, so here my patient is fond of eating what? Fond of licking what? Wall paint, right? Wall paint. After that, she is having so many symptoms. After that, she is having symptoms like acute abdominal pain. Okay, so acute abdominal pain, I hope you have learned in your forensic medicine, in lead poisoning, in a topic of the toxicology. Lead poisoning, acute abdomen pain. Okay. One more important thing is that I have complete information that my patient likes eating paint, wall paint, and wall paint has what? Lead. We have so many information here. Lead. So the question is that why lead is added in paint, in wall paint? Why lead is an essential component of wall paint? Why? Because this is going to increase the durability. And first of all, this is going to accelerate the durability, fine. And see, this is going to increase the durability, and this is going to accelerate what? Accelerate the drying of paint, fine. See, this will also give, okay, fresh appearance, okay, fresh appearance, fine, fresh appearance. And this will also resist the moisture. So many functions of lead are there. So lead is an essential component of wall paint. But what about my patient? My patient is feeding. My patient likes wall paint a lot. So she can have lead poisoning. I hope you remember from the biochemistry that which enzyme deficiency or blockage of which enzyme is seen there. ALA dehydratase, do you remember this one? Please understand that ALA dehydratase is a zinc containing enzyme, which is very, very sensitive to inhibition by lead. Fine? Easy to understand? So high level of lead can affect heme metabolism. I hope you remember this one. Like in heme metabolism in biochemistry, you have learned by combining with sulfhydryl groups and enzymes such as ferrochelatase and ALA dehydratase. Answer is C. This question was asked in AIMS also, but please understand that this is a biochemistry question, and this type of questions are being framed in recent MCI exams. So please learn biochemistry in this fashion. Okay, last question of biochemistry for you people. A case of short bowel syndrome due to terminal ileum resection presents to your clinic with difficulty in breathing, fatigue, diarrhea, nausea, and loss of appetite. On further examination, he has glossitis and a tingling sensation in his limbs. Which of the following deficiency can cause these symptoms? Basically, this is a question of surgery. Okay, this is a question of surgery. But after that, see, in surgery, see, as per the surgery, I have one clue that patient is having what? The patient is having short bowel syndrome. Short bowel syndrome means what? Whenever there will be short bowel, short means small bowel. Fine. So what is happening here? Like in any surgical procedure, when a small intestine or when bowel got resected. Okay, so massive resection, I can say, whenever there will be massive resection. In any case, like mesenteric ischemia, mesenteric infarction, mesenteric injury, Crohn's disease, fine. In any disease, in any pathology where I have to resect a big part of short bowel, small intestine. After that, there will be malabsorption for sure. So short bowel syndrome means what? Malabsorption due to massive resection of short bowel. So in this case, in this clinical scenario, especially it is mentioned here, okay, there was resection of the terminal ileum. There was the resection of the terminal ileum. What is happening here when I tell you that, like this is, okay, so this portion, okay, no, this is the terminal ileum part, fine, no? So when I tell you that, see, this is the cecum and this is the terminal ileum part, okay, no? Ileocecal valve is here. So when I tell you that I'm talking about my patient who is a follow-up case of short bowel syndrome, okay, who had the resection of terminal ileum, what is happening here? Now this portion is gone. So if I remember the basic physiology of the terminal ileum, see, there is reabsorption of vitamin B12, reabsorption of bile salts, bile salts. So what is happening here when the terminal ileum was resected? After that, what will happen? Either there will be, after that, there will be deficiency of bile salts. Whenever there will be bile salts deficiency, okay, this can lead to, this can increase the risk of which stone? This can, okay, because this can give, okay, this can give what? Answer me please here. See, whenever there will be deficiency of bile salts, it will increase the risk of a stone formation. Which stone formation? I hope you remember. Okay, gallbladder stone. Which gallbladder stone? Cholesterol stone, cholesterol. I hope you remember some point from the gallbladder stone, that what are the risk factors for the formation of cholesterol gallbladder stone? Okay, whenever there will be increased cholesterol or decreased bile salts or decreased lecithin. So please understand that whenever there will be a resection of terminal ileum, after that there will be decreased level of bile salt. This can predispose to formation of gallbladder stone. Easy to understand. But one more important thing is there. This is also important for the reabsorption of vitamin B12. So when after this surgery, there will be deficiency of vitamin B12. Now I can understand that all these signs and symptoms are related to vitamin B12. Easy to understand. Fine. So basically, like after that, you know what? After that, patient can have which type of anemia? After that, patient can have which type of anemia? Okay, megaloblastic anemia. After that, patient can have megaloblastic anemia. But I hope you remember that megaloblastic anemia can be due to the deficiency of folate. And this can be due to the deficiency of methylcobalamin. Methylcobalamin means what? Vitamin B12. But how to differentiate? Patient is having tingling sensation whenever neurological symptoms are associated in megaloblastic anemia. Please understand that this is due to deficiency of vitamin B12, which is called as methylcobalamin or cyanocobalamin. I hope this is clear to all of you. Fine. So this was the question of surgery, but finally I asked you in like in a non-clinical manner, because when I see about vitamin A, zinc, C, B12 and all, so all these options are related to like vitamins and minerals. So if you remember the basic functions of all vitamins and minerals, you can solve this kind of surgical questions. Fine now. So here in this question, what is the answer? Answer is vitamin B12. Vitamin B12, because see all signs and symptoms. I say difficulty in breathing, okay, anemia, lack of oxygen, they're fine. No oxygen carrying capacity, they're fine. After that, fatigue, okay, diarrhea, nausea and loss of appetite. All these signs and symptoms are of what? These are the symptoms of megaloblastic anemia only. Fine. No? See, the patient will also have, okay, glossitis. And when I have mentioned that patient is having a tingling sensation in his limbs, all pictures are very, very clear that. Fine. In this surgical question, when I know that resection of terminal ileum was there, and terminal ileum is responsible for reabsorption of vitamin B12 and hepatocirculation of bile salts, I can solve this question. Fine. I hope this is clear to all of you. So this is all about physiology. Okay, this is all about physiology and biochemistry. I hope you have learned some technique of solving clinical questions of physiology and biochemistry. Okay, so that's all for today. Now, the next topic will be related to microbiology, pharmacology, and pathology. So now next class will be there. Now next class will be on Saturday and Sunday. So that's all for today. Thank you so much. Take care. See you next time on Saturday. Fine. Okay, see, 24th. tomorrow. Okay, Dr. Khalil will come online. He will be live on YouTube. So Dr. Khalil sir is going to teach you, okay, how to prepare for the like FMGE exam, December exam. So he will give you the perfect strategy. Like he's one of the finest academicians in India. Fine. So Dr. Khalil Ahmed. So he will come and he will give you the complete orientation. He will give you the guidance of the complete guidance and a strategy for the preparation of FMGE December 2021 exam. Okay. So stay connected and stay happy, stay safe, take care all of you. Thank you so much. Good night. Bye-bye.